Morning everyone. Today we are going to see about muscular dystrophies. I will be talking in general about an outlook of Becker, Duchenne and associated diseases. Let's start with Duchenne and Becker's muscular dystrophy. Duchenne and Becker, you need to know that both of them are X-linked recessive and it is caused by dystrophin gene mutation. What is this dystrophin? Dystrophin or the dystrophin gene mutation codes for the dystrophin protein, and it can also be called as dystroglycan complex. This complex, that is either the dystrophin or the dystroglycan or a dystrophin, you should know that is essential for cytoskeleton anchoring. What does that mean? The muscle cell will have actin filament, intermediate filaments inside each cell, that is for movement into inside the cell, but they have to be connected with another muscle so as to produce a coordinated action. So to connect the interior as well as the external structure of the muscle together, or to connect the interior with another muscle, so basically to connect two muscle cells in place, is performed by dystrophin, and this mutation will result in Duchenne and Becker's muscular dystrophy. That's what muscle cells, because of this, they cannot anchor properly to extracellular matrix. So the muscles will undergo pseudo hypertrophy and fibroadipose tissue replacement. Duchenne is mostly seen in young boys, but whereas Becker is seen in adult or else adolescent onset, because Becker is much less severe compared with Duchenne. Duchenne has a frame shift mutation, while Becker is non-frame shift mutation. The second condition is polymyalgia rheumatica. What do you know about polymyalgia rheumatica? In patients over 50 years, they have a proximal muscle pain and stiffness. Why? What is the pathology behind it? This is because there is systemic cytokines that are released which will impair the bursa or synovium, resulting in bursitis or synovitis. Therefore, it will result in proximal muscle pain and stiffness. But because only the bursa or synovium is affected and the muscle per se is not affected, there will be no muscle weakness, and the creatinine kinase, which are generally released by the muscles, are also normal. So here there is an elevated ESR and low grade fever is possible, but other than that the muscle will be normal and creatinine kinase is also normal. This is associated with temporal or giant cell arteritis, where there is jaw claudication and risk of vision loss is all associated with temporal or giant cell arteritis. You should know that polymyalgia rheumatica can either exist alone or it can be associated with giant cell arteritis. It is not a definitive reason like it has to be associated. It can exist in isolation or in association. What is polymyositis and dermatomyositis? Polymyositis is, as the name says, there is muscle inflammation. So, polymyositis is characterized by proximal muscle weakness itself. So, why should the muscle be weak? It is mainly because the CD8 plus T cells and macrophages will infiltrate the muscle, resulting in muscle weakness. This is mostly seen in patients over 50 years. The key diagnostic findings will be typical muscle weakness on exam and elevated serum creatinine kinase levels, unlike polymyalgia rheumatica. This is the most important difference. When polymyositis is associated with dermatological features, then it is known as dermatomyositis. So, what are the dermatological features which you see in dermatomyositis? Dermatomyositis, there is something known as Cotron's papules, also known as mechanic hands. So here there will be violaceous papules, or it will look, the hands will look rough in Cotron's papules. What do you know about heliotrope rash? Heliotrope rash is nothing but violaceous eyelids or periorbital rash which is seen around the eyelids. There is also another dermatological feature in a dermatomyositis, which is a shawl sign, where there will be a lesion in the area in the back, including the scapula and interscapular area, where generally the shawl is worn. So these three important features are more characteristic for dermatomyositis. What is fibromyalgia? Fibromyalgia is not a musculoskeletal disorder. It is usually a psychiatric condition where women, mostly in their 20s to 40s, will be presenting with multiple tender points which are symmetric tender points. The labs and ESR will be normal. Here the treatment is SSRIs are the first line. They may be listed as antidepressant therapy on the exams. So, what is temporomandibular joint dysfunction? Temporomandibular joint dysfunction is where the joint is dysfunctioned. Here there is jaw pain which is precipitated by eating because of dysfunction of temporomandibular joint. There is a typical difference from temporal arteritis where in temporomandibular joint dysfunction, because of the problem with the joint, they will not be able to eat at all. But in temporal arteritis, there will be jaw claudication, where here in temporal arteritis, the pathophysiology will be decreased blood supply to the jaw muscles because of arteritis. Therefore, even if they talk for a while, after that they will not be able to talk. Even if they eat or chew hard food, after that they will not be able to chew. So this is known as jaw claudication. This feature is different from jaw pain, which is precipitated by eating. What do you understand by myotonic dystrophy? Here, there is an inability to relax the grip on objects like doorknobs or golf clubs, or they will not be able to release the handshake. This happens in myotonic dystrophy, which is due to CTG repeats, the trinucleotide repeat expansion disease. Normal individual have fewer than 35 CTG repeats, but when there is 50 plus CTG repeats, it results in myotonic dystrophy. What about hypothyroid myopathy? Here, the thyroid hormone deficiency will affect the muscle metabolism. This is generally seen in hypothyroid as well as a hyperthyroid, but hypothyroid myopathy is much more common and it can result from Hashimoto's thyroiditis. Here there is proximal muscle weakness and elevated creatine kinase levels. So they will give you a vignette with fatigue, dysthymia, menstrual irregularities, cold intolerance associated with myopathy, which points towards hypothyroid myopathy. Drug-induced myopathy. Drug-induced myopathy can be because of either statins or fibrates, or the combination of statins and fibrates are much more can cause myopathy. So when the person takes statins, because of drug-induced myopathy, there can be elevated creatinine kinase. So they might ask you, if there is an elevated creatinine kinase, should statins be stopped? Not necessary. Mild elevation of creatinine kinase one does not need to stop statins. What about mitochondrial myopathy? Here, it is associated with hypotonia, with eye or ear problems, as well as lactic acidosis. This is the triad for mitochondrial myopathy. And the most common pathognomic feature on muscle biopsy is ragged red fibers. Mitochondria, we know that it is present in the ovum, that is therefore, and not in the sperm. It is of course present in the sperm, but that part of the sperm which enters the ovum, that is the acrosome, that doesn't contain the mitochondria. So any mitochondrial disease will be exclusively maternally inherited. And even the mitochondria which is present in each ovum will vary. The amount will vary, the quantity will vary, and that kind of the substance will also vary. Therefore, heteroplasmy will explain the variable severity. That means, depending on the mitochondria that is present in each ovum, the the clinical triad or the severity can vary. Therefore, in mitochondrial myopathy, heteroplasmy is an important feature that one should remember. In inclusion body myositis, that is mostly seen in adults over 50 years with progressive muscle weakness over months to years. Here the muscle biopsy shows characteristic basophilic rimmed vacuoles. This is the key point which you should remember. When you see basophilic rimmed vacuoles in the muscle cell, that points towards inclusion body myositis. It will affect both the proximal as well as the distal muscles, often asymmetrically. Mixed connective tissue disease. Here you need to remember a mnemonic known as like LPS. Here they will be having a features which is mixed of three diseases, that is lupus features. So either they can have photosensitivity, malar rash, arthritis, serositis, anything, or and mixed with polymyositis like proximal muscle weakness with elevated serum creatine kinase with muscle myalgia, and with scleroderma features like sclerodactyly, esophageal dysfunction. So there can be a mixture of all these three features, which is known as mixed connective tissue disease. Here the serological marker is U1 ribonucleoprotein antibodies. U1 RNP are the diagnostic in mixed connective tissue disease. What about achondroplasia? In achondroplasia, there is constitutive activation of FGFR3, which will prevent cartilage conversion to the bone. So we should know that achondroplasia is autosomal dominant condition which typically results from gonadal mosaicism in father's spermatogonia. So autosomal dominant resulting from gonadal mosaicism. So here you should know that the father's gonads have mosaicism. So the father may not have achondroplasia, but every offspring produced by the father will have the disease because it is an autosomal dominant from gonadal mosaicism. That is a different feature which is seen in achondroplasia. And sometimes this can also be asked. Like what is that responsible for achondroplasia? Constitutive activation of FGFR3 is the one which is responsible because the cartilage has to get converted to bone. Since this is activated, this doesn't happen. The children will be presenting with short limbs with a normal trunk as well as a head.